in Malad, Suchak Hospital, Asian Heart Hospital, Seven Hills Hospital. Oh. I invite Dr. Ketan Mehta to please take over from here.
Thank you, ma'am. Very good evening to all of you. Friends, welcome to this our series of Experts Talk, in which we are covering various topics relevant to family physician. And today we are going to discuss unanswered questions in rheumatology for family physician. And to answer this, we have an expert which probably our branch would have never witnessed. It is just courtesy COVID. We are having none other than a doyen in the field of rheumatology, Professor Dr. Rohini Handa, whom I know personally for almost 2 decades. Sir is a senior consultant rheumatologist at Apollo Hospital, New Delhi. He has been an ex-faculty at All India Institute of Medical Science for more than 2 decades. He has been a fellow of Royal College of Physicians, Glasgow, fellow of American College of Rheumatology, and he has been a recipient of a big list of oration awards. If we start narrating, probably we will have half the session over in that just narration only. Just to point that he has also been a recipient of a prestigious Sarkuntala Amirchand Prize from ICMR. He has been an ex-dean of Indian College of Physicians. He has been an ex-president of APLAR, that is Asia Pacific League of Association for Rheumatologists. He has also been an ex-president of Indian Rheumatology Association. He has been on an editorial board member of various rheumatology journals and also of JAPI. He has authored various chapters in so many textbooks, written n number of articles which are published in various national and international journals. He has a vast experience for almost 3.5 decades, and he has been instrumental in starting rheumatology super specialty course at Apollo Hospital. So, sir, we welcome you for this seminar, webinar, and we could meet over this. So, welcome and thanks for making a valuable time, sir. So, we will, sir, come to the questions. We have been seeing that the number of cases of rheumatology cases have been increasing in general population. So, according to you, sir, what do you think? Which are the common rheumatologic conditions which are prevalent in general population?
Thank you very much for the kind invitation to join you. Mumbai is indeed close to my heart because my children are now settled in Mumbai, and surely my association with you goes back almost 20 years. So it's a great pleasure to be joining you here. And I would like to thank you for bringing out the issue of rheumatic diseases. Now, if you look at the community, the family practice, the big four, as we call it, of rheumatology, which are the four conditions that people encounter in family practice or community practice are: number one, low back pain; number two, osteoarthritis; number three, soft tissue rheumatism; and number four, you have all the inflammatory rheumatic diseases put together. So back pain in terms of commonality is the first one. Then you have osteoarthritis. Then you have soft tissue rheumatism, in which you have tendinitis, bursitis, frozen shoulder, tennis elbow, plantar fasciitis, and the so-called glamorous rheumatic diseases like lupus, Sjogren's, vasculitis, rheumatoid, all put together come at number four. If you look at the hospital practice, say your hospital practice, this gets reversed. What you get in the hospital are the inflammatory rheumatic diseases. People with rheumatoid, people with lupus, people with Sjogren's would come to the hospital. So this is the spectrum that you see. And in inflammatory rheumatic diseases, from a community perspective, gout is quite common. And then, of course, you have rheumatoid and you have Sjogren syndrome. So this is the spectrum that people see in the community.
Okay. So very nicely you gave us a background about the prevalence of the rheumatic conditions. Now, as you rightly said, the chronic low backache, which is a very common symptom with which the patient would present. And I'm sure our family physicians see that vast array of people presenting to them. Now, always the question comes to them is one, do they just give initial phase symptomatic treatment? Two, do they start investing at after how much duration? Or and if they have to refer, will they be referring to a physician like Dr. Ketan Mehta, send it to rheumatologist like Dr. Handa, send it to orthopedic surgeon, to AIMS, or should send to a pain specialist. Now we have a specialty pain consultant. So, sir, your views on that?
They will not send to anybody. They will manage themselves, and I will tell them how to manage it. The most important thing is that when you have low back pain, you need to pick up sinister low back pain, what are called the red flag signs. So if you have an elderly patient with back pain and weight loss, back pain with fever, back pain with loss of appetite, when you have trauma, when you have back pain in the setting of malignancy earlier, say like carcinoma of the prostate, they are called red flag signs. You should try to find out, is my patient with back pain having fever? Is it more at night and during lying down? Is my patient losing weight? Is my patient losing appetite? Has he suffered from any cancer in the past? And is there any neurologic compromise? Bladder bowel to affect nahi hue. If there is sphincter involvement, neurologic compromise, then these are called red flag signs, and you need to have investigations, which will also include imaging. But if you look at family practice, this is going to be less than 1% of your cases. Low back pain is like common cold. The majority of the patients will have what is called non-specific low back pain, which means that could be postural, it could be contributed by vitamin D deficiency, it could be some disc prolapse, it could be lumbar spondylosis. So those kind of conditions are all lumped together and called non-specific. Non-specific does not mean inconsequential. Sometimes people, believe that if we are labeling it non-specific back pain, we mean that it is of no consequence. Certainly not. So you will learn to identify red flag signs. If red flag signs are not there, then you will manage conservatively. And the rule of the thumb, Dr. Mehta, is the favorable natural history of low back pain. 75-80% people will get better in 6 weeks, and only 10% to 15% would have a problem beyond 6 to 12 weeks. So when you have a duration less than 6 weeks, that's called acute. Duration more than 12 weeks is called chronic. And in acute low back pain, most people get better. So do not refer anywhere. Ask questions about red flag signs. Give conservative management, which is pain relief, stretching exercises. Those who do not get better in 6 weeks, they are the people who will need investigations. 6 to 12 weeks is the watershed zone, that is called subacute low back pain. And then, good question, who do you send to? Now, back pain is a multidisciplinary problem. You could send it to an orthopedic surgeon, you could send it to a spine surgeon, you could send it to an internist, You could send it to a rheumatologist, or you could send it to a pain specialist. The choice is yours. But remember, 6 weeks, most people get better. So if your patient is turning the corner, there are no red flag signs, manage it at your level. If things are not settling down, then you need a referral, and the referral could be any of these colleagues. But let me tell you, surgical requirements are less than 1 in 1,000 or 1 in 10,000. So if you could very well send to an internist or to a rheumatologist, but many people traditionally send to orthopedic surgeons. This is the breakup.
Right. So you have very nicely said about the different array and how the things are taking a detailed history, which is of very utmost importance and can give you elucidating red flag signs, which will also add value to it. Now, nowadays, what has happened? I don't know about New Delhi, but in the Bombay, there are a lot of physiotherapy centers have started, and people started feeling, that with backache, it would be directly just go to a physiotherapist. They will teach certain exercises for a chronic low backache, and will be okay. So, you think is that the right way of doing? Because so often it is not known what is the cause. So, would you think is that the right approach, sir?
Very pertinent and a very practically relevant question. You see, the practice of chiropractor is not so common in our country, and physiotherapists handle all kinds of pains. And many people do go to the neighborhood physiotherapist. But the skill set which a doctor brings, the same cannot be said of a physiotherapist. A physiotherapist is a team member who helps to mitigate the pain by demonstrating exercises, by using things like hot and cold application, ultrasound to help the patient improve. But a physiotherapist, to my mind, cannot be the captain of the team. He's an important player because that nuance to see whether there is sphincter involvement, whether there is a suspicious lump, whether there is a history of carcinoma of the prostate, or in a elderly lady it could be osteoporotic fracture. I would believe that one should pair up as a team, but primary management with a physiotherapist without a medical consult with the family physician or one of the allied specialities, I feel perhaps is not in the best interest of the patient.
Basically, obviously, as you said, that predominantly coming to what are the pointers towards the specific cause, and that could give a final answer to it rather than just pending it. So that's a very nice way of elucidating. Let's move to one other spectrum, which commonly the family physician see. Somebody presents to a family physician with a unilateral swelling of great toe, and obviously now all our senior practitioners are well versed with the great teaching by the various orthopedics and rheumatologists, so immediately they start sending, oh, this is, they come to jump to the conclusion this is nothing but a gouty arthritis, and the first thing they send is a serum uric acid. Now the problem comes, the patient comes with uric acid level, sees, oh, my uric acid is within normal limit, and how do you go about such cases, and is it common when still uric acid being normal and still it could be a gouty arthritis?
Excellent question. If you look at the inflammatory rheumatic diseases, we talked about back pain, we talked about osteoarthritis. The spectrum of inflammatory rheumatic diseases is dominated in community practice by gout. Now, gout is a clinical biochemical diagnosis that you need to have clinical constellation, which is a lower limb joint, big toe mainly, but you could have middle of the foot also, you could have ankle also, you could have knee also, and it usually can be either side. Occasionally, particularly in the elderly, You could have upper limb involvement and bilateral involvement also. As people, the longevity of Indians is increasing. The gout in elderly can affect upper limbs and can be bilateral. But let's talk about the textbook picture. Now, if you have a classical podagra as you are describing, you may still have a normal uric acid because in response to pain, your body is going to secrete ACTH, and ACTH is uricosuric. So what would happen is that your uric acid levels during an acute attack may be normal, and after a few days to weeks, they may climb up. So, if you follow up the patient consistently and persistently, at some stage you will start detecting elevated levels. Having said that, normouricemic gout is not unknown. Just like these days you have, a normal ejection fraction heart failure. You are an internist. When I was a student, heart failure meant low ejection fraction. Now people talk about normal ejection fraction heart failure. People talk about amyopathic dermatomyositis. You have dermatomyositis, but muscle is not weak. So these kind of oddities are uncommon but not unknown. So normouricemic gout is well described in literature. So how do we pick it up? There are two additional modalities of picking it up. One is that you do a joint aspiration, and from the big toe joint, you aspirate the synovial fluid subjected to crystal analysis. And the second is a non invasive modality called dual energy CT. Now, dual energy CT is now becoming increasingly available, and dual energy CT will show you crystal deposits around the joint. It can also tell you crystal deposits at silent areas. It will give you an estimate of the urate burden. The third modality, which is operator dependent, is ultrasound. So you pick up gout in five ways: clinical picture, the time honored uric acid, you do a crystal analysis, you do dual energy CT and ultrasound. The problem with ultrasound is that it is highly operator dependent. And if somebody is used to doing musculoskeletal ultrasound, only then would he be able to pick up the double contour sign and features suggestive of gout. With MRI, with dual energy CT, the operator, this variability is not there. So these are the modalities where you pick up when the uric acid is normal.
Right. So, sir has given a very nice message that even a normal serum uric acid does not exclude that could be a gouty arthritis. Now, as opposed to that, sir, quite often what is happening now, the patients have been sent for routine executive health checkup, and then they come back to family physician that these are the abnormalities of which asymptomatic hyperuricemia, which is quite often detected. And then they will come because they know uric acid is linked to gout. So they will ask the family, do I have a gout? Am I more predisposed to? So what should be the approach in asymptomatic hyperuricemia?
Very, very relevant question, and it shows your experience. What really happens is that one has to understand hyperuricemia is a biochemical abnormality. Gout is a clinical syndrome. One of the risk factors for gout is hyperuricemia. When the biochemical abnormality combines with environmental factors, the two put together produce the clinical syndrome. So, if you do not have the environmental factors like obesity, like say binge alcohol use or red meat use or a genetic predisposition, not every people, not every person with hyperuricemia will go on to develop gout. So, with asymptomatic hyperuricemia, you should search for other reasons for metabolic syndrome, obesity, hyperlipidemia, your sugar levels which are borderline. So birds of the same feather flock together. So you make a diligent search, advise lifestyle changes, but giving uric acid lowering drugs is not indicated. So, biochemical abnormality, treat by lifestyle alone. If you have the clinical disease, treat it with a urate lowering treatment with one caveat. When the levels are very high, then some people start treating asymptomatic hyperuricemia also, because the risk of gout is inordinately deemed to be high, and those levels are in the range of 10 for women and 12 for men. बट ये जो छुटपुट 7.5, 7.9, 8.2 knee-jerk reaction of starting urate lowering treatment is not warranted. Lifestyle measures are more important.
So, a very beautiful message which is coming, a tendency for anyone to get tempted to start uric drugs, and especially now, a lot of companies are marketing aggressively with the launch of Fabuxostat, which has come. So, we need to be careful, look at what Sir has said about the lifestyle changes which requires, and really need whether this patient has got some clinical manifestation of it or no. Okay. Now, sir, coming to back to as you said about the normal uric acid in a gout or somebody where you know that now he has got a gouty arthritis. So, what uric acid target will you look at what level will you? Because all of these you will be starting subsequently for a uric agent. So, what levels do you look at achieving the target? Would you bring down till 3, 4, or 5, or still lower? And at what dose you will reduce the dose or discontinue the drug?
Very, very important questions. And before I take up this question, there is a request from Dr. Kiran Desai about slide projection. And I have to say that this was intended to be a chat show. There were no slides, so my apologies. I have no slides. And Dr. Mahmood Merchant has asked about diagnosing Angst-Spawn, which I think I will answer if Dr. Mehta permits me later on. Let me come back to this question of target. Now, what happens is that you define a target of treatment for every disease. Just like in diabetes, you have a HbA1c less than 7, and you tell people that you have a HbA1c below 7. You also have a target for cholesterol, you have a target for blood pressure. So the target for uric acid is 6. And what you should do is treat to target, which means that you start your allopurinol or xyloric in a low dose, say 100 milligram or 200 milligrams, and build up rapidly. So you achieve the target in some people with 300 milligram, in some with 200 milligram. So the target of treatment is a uric acid of 6 and lower. If you have a person with tophaceous gout, tophi are there, then you aim for a uric acid of 5.5 or even less so that the tophi can melt. So that is the target. And based upon this target, you up titrate or low titrate your dose anywhere from 100 to 800 milligrams of xyloric or allopurinol. So be very slow in escalation. So first contain the disease, then maintain it for months together, and then reduce. Contain, maintain, and reduce. And this general principle is valid for most rheumatic diseases. Only thing is that in rheumatic diseases, you have to be patient, and your patient has to be patient. There is no tatkal seva. With rheumatoid, with gout, with Sjogren's, with Angst-Spawn, you need to be patient.
Right. Okay. And you want to cover right now about the question from Dr. Merchant about a simple way to diagnose ankylosing spondylarthropathy and what is DISH and how to diagnose. Yeah.
Excellent. A very important questions. And if you look at, we talked about rheumatic diseases. We said number one is low back pain, number two is osteoarthritis, number three is soft tissue rheumatism, and then you have the inflammatory rheumatic diseases as a group. And in inflammatory rheumatic diseases, you, Dr. Mehta, picked up the most important one, gout. The next is rheumatoid arthritis. The third in commonality is Sjogren's syndrome, and then you have ankylosing spondylitis. Now, ankylosing spondylitis is a flagship disease of the big group called spondyloarthropathy. Spondyloarthropathy is diagnosed when you have a young patient, usually less than 40-45 years. Males outnumber females by a ratio of 2 to 3 is to 1. So you have 2 to 3 male patients for every woman who's diagnosed with angstpon. And when they come with inflammatory back pain, so unlike the garden variety of back pain, the patient's history would be, when I wake up in the morning, I am stiff. जब खांसता हूँ छींकता हूँ खांसी रुक जाती है छींक रुक जाती है that I cannot cough well sneeze well when there is costochondritis or rib pain when there is along with pain alternating buttock pain pocket area pain when the patient says कि back pocket area में pain है that is the setting when you start suspecting that this is not a mechanical low back pain. So morning stiffness, difficulty in turning sides in the bed. Mornings are worst, afternoons are better. You have rib pain. Patient cannot cough or sneeze properly. Complains of buttock pain, sometimes right, sometimes left, or heel pain, plantar fasciitis. And if you get a history of red eye uveitis, you then start thinking in terms of ankylosing spondylitis or spondyloarthropathy. Now, ankylosing spondylitis is one. Then you also have in this group psoriasis, ulcerative colitis, reactive arthritis, juvenile onset spondyloarthropathy. So, ankylosing spondylitis is one extreme end. Many people have more subtle forms. So, the big group is spondarthritis. Now, what is DISH? DISH is diffuse idiopathic skeletal hyperostosis, which is a degenerative condition. You have very exuberant osteophytes, and this is non-inflammatory. The sacroiliac joints are spared, and HLA-B27 is not associated. So DISH is a degenerative condition, happens in middle to older age group. You have sacroiliac joints being spared, whereas with ankylosing spondylitis, the fire starts in the sacroiliac joint. And in this, you could have more on the right side of the vertebral column. So this is a degenerative condition. Now, the next question that Dr. Merchant wants to know is how important is B27? And I think, Dr. Mehta, you raised the issue of normouricemic gout. So 90% people are going to be B27 positive, 10% are going to be HLA B27 negative. The two messages are you can have ankylosing spondylitis without HLA B27. And the second equally important message is that not all HLA B27 people have angstpon. If you look at North India, 8% of the population in North India is HLA B27 positive. Only 10% of these people will develop ankylosing spondylitis. 90% people would not have any disease relating to HLA. So if you look at the community, the disease becomes manifest only in 10% of the people with the gene when environment comes together with the gene.
Right. So you have a very nice idea about that we need to definitely look at the clinical presentation in toto and not just looking at whether there is a presence or absence of HLA-B27. So let's move on to RA, which we know the common thing. Now our conventional teaching about the RA, when somebody was suspected, we used to ask for a RA factor, RA test. And in last one decade, the things have changed. So, sir, would you put asking the stress of anti-CCP antibody directly, or you ask for a RA factor, and if negative and still suspicion is there, then only you ask for anti-CCP antibody?
Very important question. You see, rheumatoid is a clinical diagnosis. Rheumatology is not high tech, it is high touch. So you need to touch your patients, touch the joints, move the joints, feel the joints. So we are high touch, but we are not high tech. So that's the number one message. Now, with rheumatoid arthritis, unlike gout, upper limbs are affected, small joints are affected. It is bilaterally symmetrical. And if I have to describe the phenotype of rheumatoid, whenever you have a woman who comes to you with bilateral small joint involvement, upper limbs are affected, morning stiffness is there, and you are able to palpate the joint and get synovitis, that is rheumatoid. You do not need a rheumatoid factor to diagnose rheumatoid arthritis. The rheumatoid factor is positive in about 80% people. 20% people are going to be seronegative. And seronegative people are picked up on clinical examination only. Now, you can have RA without rheumatoid factor, and you can have rheumatoid factor without RA.
Oh,
Viral hepatitis can trigger rheumatoid factor. Tuberculosis can trigger rheumatoid factor. Sarcoidosis can trigger rheumatoid factor. Interstitial lung disease can trigger rheumatoid factor. So you can have both scenarios. RA without RF, that's called seronegative RA. RF without rheumatoid arthritis. Now there is a question by Dr. Neeraj Shah on RA qualitative and quantitative. Well, we actually these days only ask for quantitative test because the latex test is no longer much used. Most big laboratories use ELISAs. If the levels are high, this means that you are likely dealing with a more significant condition. It could be vasculitis, it could be sarcoid, it could be tuberculosis. But generally, most labs now do a quantitative test, which you interpret along with the clinical history. You talked about CCP. The sensitivity of CCP is not any better than rheumatoid factor. Specificity is more. So if you have 10 conditions which can trigger rheumatoid factor, anti-CCP in high levels are triggered by and large only in rheumatoid arthritis. So you can have four scenarios. You can have a person of rheumatoid arthritis who is RF positive, anti-CCP positive. Both are positive, it's called a double positive. Both could be negative, that is called a double negative. And you could have one being positive, other being negative. So anti-CCP could be positive, rheumatoid factor could be negative. Rheumatoid factor could be positive, anti-CCP could be negative. So all four serologic combinations happen, both positive, both negative, one may be positive. And the clinical management is not affected much by this serologic subtype. No matter what the serologic subvariety, the treatment remains the same. Methotrexate is the number one drug, followed by hydroxychloroquine.
Correct. So, as you again rightly said, there is obviously more of a clinical judgment which will be deciding for the factor and not on the basis of just going for the lab parameters. Here, I would give an example for somebody, young lady comes with a skin lesion, gets treated by family physicians for whatever think of, and then subsequently she develops a joint involvement, and now he thinks, no, there is something which I need to investigate with the classical facial skin lesions with a joint involvement. And the first thing, because he knows the workup is going to be expensive, so there are two ways: either he can think of sending it to a physician or a rheumatologist, or he starts working out. So the first common thing which is asked is a CBC ESR which is done. So would like to know if ESR or every additional CRP is done. If both are normal, does the patient still can have or suspected to have a lupus, or should he still go work up for SLE, or ESR and CRP normal will rule out SLE?
You see, nothing in rheumatology ever replaces the judgment of a seasoned clinician. I have already said it is a predominantly clinical subspecialty. If I have noticed a butterfly rash, if I have my hands have picked up clinical synovitis, even if the ESR is normal, CRP is normal, I would not change my diagnosis. And this phenomena is called clinico-serologic discordance. Some people are clinically active, but ESR, CRP are normal. Some have very high ESR and you don't find any disease. So when you have clinico-serologic discordance, you give importance to your clinical things. So even if your ESR, CRP is normal and you have noticed a butterfly rash or oral ulcers or joint swelling, you still need to work up your patients for that. And then we've got a question here which talks about, how often are the kidneys involved in rheumatoid? In rheumatoid, the commonest reason that you get kidney involvement is NSAID use. NSAID use, discriminate or indiscriminate, is the reason for kidney involvement. But you do get kidney disease, interstitial nephritis with rheumatoid arthritis also, not very common. Glomerular disease with rheumatoid arthritis is not very common. In the olden days when treatment was not there, you got amyloidosis also. But currently, the most important reason for kidney disease is the use of anti-inflammatory drugs, and the second reason could be an overlap with connective tissue disease. Otherwise, significant glomerular disease is not very common. And then I have a question from Dr. Shah Jagdish here. When will you reduce Dmrd if patient symptoms are under control? And if you permit me, can I answer this?
Sir, we will come to therapy little bit later. We will just
Okay.
come with that. So, sir, here coming back to our case, now even if ESR, CRP normal, obviously he would like to work up further. The first thing he would ask is the ANA, which is commonly asked for. And now, because there are a lot of labs which are offering the LE panel where they will start doing ANA, NTDS, DNA. They will ask for lupus anticoagulant. So, what do you suggest? Is it advisable to ask for a panel or just ask a first ANA and then proceed further?
You see, actually, we should not put the cart before the horse. First, you have to have the horse and then you have to have the cart. So, for a person like me who strongly believes that you see investigation should be minimum, parsimonious, economical, first I order a screening ANA. ANA is a sensitive test. If a well performed ANA is negative, lupus is virtually ruled out because 99% of lupus patients are ANA positive. A positive ANA may or may not mean SLE, but a negative ANA rules out SLE. Only if a ANA is positive, then you do subsetting and you call that ENA.
Right.
But panels upfront, no.
Yeah, so that is obviously a commercial angle from which the labs are coming out when offering it. But as you said, ANA should be the basic test, and then depending on that, we can go for a screening for it. So here, again, I would come to another scenario where patient has got a multi-system involvement, has got a skin lesion, renal involvement, hepatic involvement, thought to be vasculitis or a rheumatic conditions which is involved. So, in how do we proceed for it? Asking for again, there are various panels available for a vasculitis workup. The labs, there are few labs, where they will ask for a P Anka, C Anka, will ask for APLA, anti-cardiolipin antibodies, and all. So, as I presume, you would be against going for this panel.
100%. Vasculitis has a particular feel about it. And that feel comes from the fact that when you have a high leukocytosis, if I am finding a leukocyte count of 15,000, 18,000, no infection, platelet count is high, ESR is high, CRP is high, the first thing that I would put my money on is a urine examination, because kidney involvement determines prognosis, and kidney involvement you can pick up only if you are doing a urine examination. I would do a urine examination first, and then to try and find out what is triggering the multi-system disease, you need a chest x-ray, you need ANCA levels, but try and find out the extent of organ involvement. And the single most important test for picking up kidney involvement is a urine examination. And once you find that you are indeed dealing with a multi-system disorder, you ask for an ANCA test.
Uh, Here, another point is, as you mentioned, as ANA being a screening test for lupus. So, what about for rheumatic arthritis? So, ASLO or ASO titer normal, does it rule out a rheumatic factor, or ASO titer normal and still patient can have rheumatic arthritis?
Well, you see, as I said, that ASO is just a test which tells you about proceeding streptococcal infection. And in what one has to understand is that rheumatic fever licks the joints, bites the heart. This is a age-old saying. आप कुछ भी दवाई मत दो. The joint pain of rheumatic fever gets better. 90% people get better without treatment in 12 weeks. जो ठीक हो गया वो rheumatic fever, जो बच गया वो juvenile arthritis. So if you have a child coming with joint pains for 6 months on a wheelchair with deformities, that is not rheumatic fever. Rheumatic fever problem comes in the heart. So you need a echo to pick it up. The joint disease of rheumatic fever does not lead you with deformities. Jacob's deformities occasionally come up, are correctable, but if you have erosions, multiple joints being affected, non-migratory pattern, child in a wheelchair, you have to think in terms of a juvenile rheumatoid arthritis rather than rheumatic fever, and over-reliance on ASO gives rise to diagnostic delays. But as students, we were taught in pathology ASO equals rheumatic fever, which is not true.
So that's a very important message which you have given. Now we will come to the therapy aspect. So suppose a patient, now you've been diagnosed as now coming into category or fitting into rheumatoid arthritis, which you see. So when will you start steroids? When will you give only NSAIDs? And when you will consider DMRDs?
Actually, most people who have rheumatoid arthritis, the anchor drug is methotrexate, and all people where the diagnosis is secure should be given methotrexate. NSAIDs are utilized only for the short term before the DMARDs can act, and NSAIDs use is limited to a few weeks only. But the bulk of the treatment is going to be based on your methotrexate, and because methotrexate takes time to act, the first few weeks you bridge this gap between institution of methotrexate and before it effect comes up. Those 8-10 weeks you use bridge therapy with steroids. So when you have a fresh patient of rheumatoid who's active, you will start all three together: NSAIDs, corticosteroids, disease modifying drug. NSAID you will withdraw in 5-6 days once the pains are better. Steroid you will continue for 8 to 10 weeks called bridge therapy, and you will withdraw them, and you will continue with drugs like HCQ or methotrexate for long periods of time.
Right. Now, that's a very important message that the NSAID should not be continued on, as sir has said, because we have seen, our patients get used to it. They start feeling better in terms of pain, severity, and all, and they tend to continue that of their own. And that is the one most dangerous thing which we see patients land up with, coming with acute kidney injuries, coming with high creatinine and all. So we know that there is an affection of the kidney which can come because of the disease per se, and second thing is coming because of the therapy per se. So whatever iatrogenic factors we as a clinician can avoid, we should try and do it. So NSAIDs to a minimum there. So here's a quick question: your choice of NSAIDs, your choice of steroids, and DMRD you already mentioned. So between the two, choice of NSAID and
There
choice
is
of
there is nothing to choose in the, anti-inflammatory drugs. All work the same way. So it is your physician preference. Generally, once a day are preferred. So you will utilize one of the coxibs. But at the end of the day, no one is better than the other. If somebody has a cardiac condition, naproxen is preferred in people who have cardiac conditions like coronary artery disease. Steroid, no two words: cheap, simple, economical prednisolone. You gain nothing by adding methyl prednisolone or deflazacort. There is no science to support that. And for disease modifying drugs, you have four disease modifying drugs: HCQ, hydroxychloroquine, methotrexate, sulfasalazine, leflunomide. The two top drugs are hydroxychloroquine and methotrexate. I would also have to, sir, remind you that five, I have a video thing. So I have some constraints of time.
Yes, yes. So we'll be just finishing in 5 minutes.
Yeah,
So now, sir, somebody who has been put on DMRDs by you and goes back to family physician, so he can't come back to you. So what monitoring is required by a family physician who is on DMRDs?
excellent. And before I answer that, there is one very important question from Dr. Subhash Gajiria on what is the urine abnormality in vasculitis, which I must answer. Any urine abnormality means protein in the urine, proteinuria, and the presence of red cells. Hematuria, proteinuria, and red cell casts signify active urine, whether it is lupus or vasculitis. So look for red cells, red cell casts, and proteins. Now, coming to your question, you see, all rheumatoid patients should be encouraged to go back to their family physician. What they need is a complete blood count: HB, TLC, TLC, ESR. They need SGOTPT for liver and serum creatinine for kidney. These are the basic tests which should be done every 3 months or 4 months. And if the TLC is maintained above 4,000, platelet count above 1 lakh, and if the OTPT are below 3 times the upper limit of normal. So if somebody is below, say, 70 or 80, you continue with the disease modifying drugs.
Right. So that's a fantastic message. Sir said that the patient can go back to the family physician and proper monitoring can be done. So now, sir, what is the difference between DMRDs and the biologics? Now the people are using biologics. So can you throw some?
Excellent question. and biologics target specific molecules. And if I have to give you an example, biologics are to rheumatology what insulin is to diabetes: superior relief, better control, but not cure. They help reduce the inflammation, they improve disability, they improve function, and above all, in rheumatoid arthritis, benefits on X-ray progression. Erosions can heal. So, if there is a drug in coronary artery disease which lowers cholesterol, another drug reduces heart attack, and a third one reduces mortality also. So, if you have a drug which will lower cholesterol, reduce heart attack, lower mortality, you will prefer that. So, biologics reduce pain and inflammation, prevent disability, and help the radiologic endpoint, which is like mortality in coronary artery disease. And biologics give you superior relief, and in conditions like ankylosing spondylitis, they make a difference between existing and living. जिसने खांसा नहीं होता, छींका नहीं होता, सोया नहीं होता, you have to use them to believe what they can do.
Right. So that was a fantastic explanation. And my last question, sir, what is there a role of nutraceutical elements or nutritional components in rheumatology per se?
Excellent question. There are two ways of answering this question: the science of medicine and the art of medicine. And the science of medicine is no role. If you look at the guidelines for osteoarthritis, except thumb osteoarthritis and the role of diacerine, most guidelines say do not use them. Glucosamine, diacerine, no matter what, MSM, nothing. But if you look at the art of medicine, about 50% people get a variable degree of benefit with these nutraceuticals. So I explain it to my patients. They do not have any serious side effects. I say, I'm going to give you a trial of these agents. Those who do better, they continue on that. Those who do not do better, they do not continue. So the art of medicine is discuss it with your patient, try it, and in carefully selected patients, they derive symptomatic benefit with virtually no side effects. The science of medicine is they don't help.
Thank you so much. It was a really a eye opener, and the way you have given all the points, it was such a lucid way. I really thank Dr. Handa for making it possible and having a valuable time with us. So thank you so much, sir, for your time. And I would just request Harish from the care to say a few words before we give vote of thanks. Harish.
Hello,
Yeah, Harish.
hello.
Yeah.
Dr. Rohini Handa, and good evening all the participants. Myself Harish Mehta, working as a marketing manager, and this webinar is organized by the InnoCare Life Sciences Company, private limited company, and with the help of IMA Mumbai West. Uh, just wanted to give you a brief idea about the company. InnoCare Life Sciences is 5 years old company, Mumbai-based company, and operating across all India. InnoCare Life Sciences is known for innovation and always known for innovative product. And we are the makers of Tendo Shot, Instaactive OA, and also we have a Cola Shot range. Uh, Instaactive OA, which is our one of the fastest growing brand,
Tell
which
me.
contains natural eggshell membrane, which also contains nanoglucomin, Boswellia serrata, sodium hyaluronate, vitamin C, which also contains manganese and bioprine. And the unique thing about this brand, Doctor, it's the first brand in India with a combination of natural eggshell membrane along with the nanocurcumin, and this nanocurcumin with available with the nanotechnology. And the
Hello.
benefit of the
My
combination that
audio is very
reduces pain,
clear.
stiffness, and improves joint function within 10 days. It improves 20% or reduces pain up to a 20%. Within 10 days, reduces 20% stiffness and
Hello.
also improvement in a physical function. Apart from this, we have another brand for tendonitis and tendinosis. We have Tendo Shot, which tackles pain, relax muscles, and also improves the mobility in the patient. And the unique thing about this Tendo Shot, doctor, tendo shot can be prescribed in various tendinopathy like hand and shoulder tendinopathy, where the rotator cuff, golfer's elbow, tennis elbow also can be prescribed in a leg and foot tendinopathy, and also wrist and finger tendinopathy. So, from the entire InnoCare Life Sciences, we just wanted to say thank you so
Hello.
much, Dr. Rohini Handa and Dr. Ketan Mehta, for giving a valuable information, insights, which is related to rheumatology.
Hello. Gopa, can you hear me?
Okay.
Thank you very much, and I would like to thank you
Rashmikant,
for inviting me.
Thank you,
And
sir.
I see a lot of questions there, and
Yes.
if we have more time, sometimes I would be
Hello.
delighted to answer those practical questions.
Hello.
Thank you, sir.
Yes,
now I will
Okay.
request Dr. Rashmikant Bhai to
And
propose
here?
vote of thanks. Rashmikant Bhai? No.
No, you can give. That's fine.
Rashmikant, please tell Akhil.
Yeah.
Ketan, please tell Akhil.
No problem. So, on behalf of IMA Mumbai West, we thank all the participants. Our special thanks to Professor Dr. Rohini Handa and, of course, InnoCare for giving unrestricted educational grant. Thank you so much. We'll see you
Bye-bye.
in the next series. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.